welcome back to the podcast. This is the Func Med Nation. It's been a while since we've hosted any interviews, and today it's my pleasure to have a conversation with Dr. Peter Kahn. And we're going to be talking about SIBO, small intestinal bacterial overgrowth today, and getting Peter's perspective on that. I'm sure that we all see it a little bit differently and perhaps approach it a little bit differently. And I'm looking forward, Peter, to getting some of your insights. But before we do that, let's just talk about your background. We can spend as much or as little time on this as we wish. But I'm always interested in hearing how people got into functional medicine and just kind of what your journey was. So just give us a brief overview of what your background was like, and we'll just kind of take it from there.
Yeah, thanks for letting me share, Stephen. So I grew up in Taiwan, and so it's Chinese culture. I moved to the U.S. when I was 12.
Yep.
And I had a pretty solid cultural background. And my dad, he's an interesting guy. He's kind of like an, if you will, amateur healthcare, kind of like what people these days, Googling internet, looking for like, oh, what supplement is good for this? He was doing that back 40, 50 years ago. And I remember he would like take newspaper clippings, like, oh, here's an article that says tomato fight cancer. He'll clip it and he'll like save it. We had like stacks of newspaper of him saving like these health articles before there was an internet. So he was very much into, health and nutrition and things like that. And then, so we moved to the States. I have my bachelor degree in exercise physiology with a minor in nutrition. And then later on, I went to chiropractic college. And what happens is during chiropractic college, my father was diagnosed with liver cancer, actually stage 4. He had me, I'm children from a second marriage, so he had me when he was older. So at that time, when I was in chiropractic college, he was already 75, diagnosed with late stage liver cancer. Doctor said, hey, 6 months to live. We don't do liver transplant for somebody his age. Just, take care of your affairs. So at the time, my brother is also a chiropractor who graduated ahead of me. We just kind of refused to accept that. So with what little we know, we implemented some supplements like milk thistle and this and that, and have him, change his diet. And then 5 years later, he lived symptom-free. Well, he lived for 5 years symptom-free, and then he passed away very quickly at the end. So that taught me a lot, right? That taught me that the body has an amazing ability to heal itself. And, even though I was very green, I didn't know what the heck I was doing. Just that little things we did really helped him.
Yeah.
And then when I had kids, my older son, he had a scalding injury where hot boiling water spilled down the side of his body. He had third-degree burns over 15% of his body. This was in Canada, by the way. And so I had to fly up there, get him back to the States, take him to the burn center. And so that was pretty traumatic for him. And that's when he was just only like 2 years old. And ever since that scalding injury, he's developed severe respiratory symptoms. He developed severe night terror. Every night he'll wake up screaming. He developed a lot of like these emotional issues. And at some point, I thought he was going to become autistic. And so that led me down the road of studying functional neurology. I already had a big interest in that. But at that point, I decided to study under Dr. Robert Melillo, and got my fellowship training in child development disorder just to to help my son. And so that's how I got into functional neurology, and later on got board certified as a chiropractic neurologist, just like you.
Yep.
And then fast forward, my third child, my daughter, when she was a 9-month-old baby, she kind of crawled up to Big Brother's leftover lunch that was like cheese quesadilla. And she took a bite of it, and she had anaphylaxis, swelled up, had to take her emergency to the doctor's office, and then she was rushed through through the ambulance because of anaphylactic reaction to dairy at the time. And I just remember sitting in the ambulance with her, and I was like, I need to figure this out, So, and that led me down the road of studying gluten sensitivity, functional medicine. So that's how I really got into it. So starting in 2009, that's when I really took the training that I had and really put it together and took it seriously and really bring it out to patients, and started really more of a chronic conditions practice where I saw people with Hashimoto's, thyroid problem, autoimmunity. And that's kind of what got me to here today, since 2009, seeing a lot of people with chronic issues. And I consider it a privilege because as you know, Stephen, when you do this long enough, you have your shares of wins, and you also have your shares of case failures where people didn't
No, we
respond.
don't like to talk
And
about the
it's always like,
failures.
yeah, well, I'm just being honest, right?
No,
Because
yeah,
but
I'm
the
being
failure.
facetious, right? Yeah,
Oh yeah, yeah, no, I totally understand.
yeah,
But no, I think the failures is what it's like a privilege. You get to practice on people,
yeah.
right? It's almost like I'm so grateful for the opportunity to fail, because only through that you learn. I mean, there's also miracle cases, but it's the failure cases that scratch your head and help you to figure it out later.
Yeah.
So that's kind of my journey, and hopefully that helps somebody to know that to continue to learn and don't give up.
So what was your first exposure to functional medicine? Because I know that a lot of people who are involved in functional medicine, say in our circles, their first exposure was through Apex Energetics, and whether it's seminars that I taught or any of the other speakers that have worked for Apex over the years. Was that your entry point, or did you get into it, say, through Functional Medicine University or some other group that was teaching Func Med?
Yeah, and that's a great question. I will say definitely Apex and Dr. Karazian and you yourself, I took in seminars that was taught by you,
Yeah.
were instrumental in my learning. That really helped me to just clarify the models and the framework, right? To put all these information in an organizable way so that I could actually implement it. I think that was tremendously helpful. But as I think back, I think my foray into functional medicine was actually in chiropractic college, exposed to applied kinesiology, AK. Because that was kind of like functional
Yeah.
medicine, except muscle testing instead of
Yeah.
labs, because it was all very functional nutrition. So I already was very interested in that. And actually, I'm a certified AK practitioner. I don't practice AK per se, but I have that background,
Right.
right? And then later on, I did a lot of seminars in nutrition through Standard Process and other people. That's kind of like touched on functional medicine, but not to the degree of thoroughness and completeness and just this complete model that Apex really taught me.
Yeah, and so I have no background in muscle testing or AK. That just wasn't the path that I walked through in chiropractic. So I'm kind of interested because I do interact with a lot of practitioners and have over the years who have a background, some of whom it's just one of their one tool in their tool bag, and others they rely very heavily on it, almost to the exclusion of other things. Was it difficult for you to shift your mindset from, and I'm making an assumption here, but was it hard for you to shift your mindset away from all I need to do is muscle test and the body will tell me what it needs, to now we need to look at diagnostics and labs and get some, I might offend some people here, but get more objective data? Was that a difficult shift for you, or was it easier just because of the way your mind worked anyways?
Yeah, I think I'm always very willing to try. I think one thing about me, and a lot of, I think, natural alternative practitioners, especially chiropractors, we're not afraid to try.
Right.
This is why
Yeah.
so many chiropractors, they used to practice in rural areas. They were the primary doc. They had to figure out for that person in that rural area because there was no medical doctor
Sure.
around. So
Yeah.
chiropractic has always been at the forefront of just doing primary care. And for me, I was willing to try anything: muscle testing, energetic testing, bioresonance testing, functional labs. And I think for me, the muscle testing was interesting, but there's a lot of variabilities in muscle testing because I think it takes a lot of I think it takes someone that's gifted and able to keep their mind straight when they're doing the testing. And so I think for me, it wasn't too hard for me to incorporate labs.
Right.
At some point, I did both. I think both give you some type of data, but I would never use muscle testing to say, oh, you have celiac disease, or oh, you have this XYZ. I use muscle testing kind of when it comes to a implementation point. Okay, is it going to be this vitamin C or this vitamin C?
I see.
I'll do something like that, but I would never use it in the form of you have anemia or you don't.
Right.
You have mold or you don't.
Yeah. Yeah. Yeah, and I appreciate that perspective because, like I said, I don't have a background in AK, so I've always had that question, and I've always wondered, why is it that some people choose to make that their primary diagnostic approach, and others like you, it's just a part of a process. So let me ask you, and I know we we want to talk about SIBO, but you sparked some interest just in my mind. Um, you had mentioned about your first exposure with functional medicine in the Apex model, we'll call it. And for anyone who's new to the podcast, I've taught for Apex Energetics since 2008. I'm not employed by them, but they're near and dear to my heart just because I've worked with them as an independent contractor for quite a long time. But one of the things that we stress, especially in like the blood chemistry course, is an organized approach to human physiology, right? Because human function is hierarchical, right? It's sequential, it's hierarchical, and there are certain functions that are more fundamental to how your body works than others. And so I think one of the reasons why it's easy for people who have a functional neurology background to merge into functional medicine is because functional neurology kind of trains you to think in that hierarchical fashion, right? There are systems that are integrated units in and of themselves, and then there are systems that are integrated with other systems. And that seems to be kind of a natural marriage. And I found this in talking to many other neurodiplomates that also do functional medicine, is that, again, that transition seems to be pretty seamless. I'm going to flip the question around, and I hope I don't throw you with this, but what's the downside of not having some kind of a unified systems-oriented clinical model? And maybe we can use that to merge into the discussion about SIBO, because I think if you don't have the right perspective on what SIBO is, you're going to miss a lot of opportunities. And I think having an organized hierarchical perspective on SIBO as a dysfunction of the brain-gut axis, I think that's the right starting point. So let me just back it up and rephrase the question. What's the downside of not having a unified, useful clinical model to guide you?
I think that's a great question. I think it always starts with asking the right question. That's how I think, and that's actually how I teach my patients to think.
Yeah.
Because if you ask the wrong questions, you can get the right answer to the wrong question, right? Because if you say, hey, SIBO, what supplement do I take?
Yeah.
Well, you're going to get a lot of answers from Google. Hey, take this, take that. But it doesn't tell you what's actually causing the SIBO, right? So having a hierarchical, or I call it a roadmap, helps you to be able to trace your roots back to the root cause instead of just grabbing at the shiny object. I think this applies to patients. This applies to doctors who are practicing. This applies to new doctors who are practicing, right? Because if you don't have a framework for how you will solve chronic problems, then you tend to just do the most obvious thing, the easiest thing, but that's not necessarily, may not be the right thing for that patient.
Right. Right. And I think that this is, everything's got pros and cons. And a lot of us, we talk about evidence-based medicine, and we've been using that phrase and that term for a couple of decades now, I think. But, a lot of times what that boils down to is, like you said, what's the right supplement? Because what I saw before I shifted how I thought and saw and understood SIBO, I was kind of thinking along the same lines as everyone else. What's the right herbal product to kill the infection? What's the right probiotic? What's the best enzyme supplement? And it really reduced my approach. And it was a point of ignorance on my part, but it reduced my approach down to a very simplistic form of functional medicine. And I would argue it's not really functional medicine, right? Functional medicine is something a bit bigger and a little bit broader. But when my perspective on what SIBO was, what it is, how people get it, what perpetuates the dysfunction, when that changed, then I could zoom out and kind of see the bigger picture. So let's do this for the sake of this conversation. Let's just make the assumption that everybody listening to our conversation, it's the first time they're hearing about SIBO, or maybe they've heard about SIBO. Let's gear the conversation towards more of the novice, rather than someone who's been around the block for a while and understands the brain-gut axis. We'll probably need to stop and define that. And I'm going to let you choose the starting point. Like, how would you, if you were consulting with me, I said, hey, Peter, I want you to be my mentor. I've heard about this thing, SIBO. I don't even know if I have it in my practice. Of course, we all do. It's probably more than we realize. How would you start to shift and change my understanding so that I'm seeing SIBO the right way?
Yeah, I think this is how I will go about it. Okay, so first you got to understand how digestion works, right? And I think to your earlier point, why does people who are functional neurologists make that transition to functional medicine really well? What's the commonality there? Well, the commonality there is that they're both based on physiology.
Right.
They're based on like a very good understanding of anatomy and physiology. Start from the basics,
Yeah.
right? And I think people who just jump into these things where they just heard the term SIBO, they hear leaky gut, and they jump right into, oh, what are the supplements? What's the protocol? Without really understanding the basic physiology, even histology and immunology of how things work.
Right.
That's really what took me to another level when I just, okay, let me dive into the books and actually read these things. Yeah. So the way I would help someone brand new to understand SIBO is, hey, first understand how digestion actually works. Well, how does it actually work? Well, digestion, as one of our great teachers, Dr. Karazian says, digestion starts from north to south. So you got to work your way through the normal pathway of digestion. So what does that mean, north to south? That means food transit from your mouth down to the lower GI tract, right? Goes this way. It doesn't go from the rectum and up. So a lot of people, when they're doing coffee enema and colonics and even probiotics, they're kind of starting at the other end, right?
Yeah.
So we have to solve all digestive problems, not just SIBO, following the path of where the food will transit. So that's north to south. Now, how far north can we go? Well, we assume just, starts in your mouth or starts in your stomach, but actually starts above, right? Supra to the mouth, which is like your brain, right? Your cerebral cortex, because ultimately your brain, the output of the cortex of the brain drives vagus nerve function. And that vagus nerve is the cranial nerve that innervates the gut that controls motility, secretions. So that's kind of where it comes from. So we have to kind of think about digestive issue, all digestive issue, SIBO included, starting with, did this person have symptoms of brain issue? Now, how do we know this person has symptoms of brain issue? Well, simply take an inventory. Do you have brain fog, depression, anxiety, short-term memory loss? You have balance problem, right? So if there's neurological symptoms, you got something going on in the brain that can affect everything downstream. So SIBO could be a result of that. So that framework is useful because then we can start at the top. No brain symptom. Good. Okay, next spot. Any teeth problem? Are you chewing your food? Do you like just speed eating? You swallow your food like a snake instead of chewing your food. Okay, no, you chew your food. Then we go to the next spot, stomach. Then do you produce stomach acid? Do you have vagus nerve input to produce stomach? We just go check the box, and then eventually we'll get to the point where in functional neurology, we call it the longitudinal level of lesion. Same thing with the digestion. What's the longitudinal level of lesion? At what point does the communication or the dysfunction start to happen? And then so we can start there instead of starting at the wrong end of the GI tract and getting nowhere with it.
So a question that I'm trying to put myself in the position of someone who knows little to nothing about brain or SIBO. I think the natural question would be then, how do you distinguish between someone who has GI symptoms that are happening just simply as a result of something that's changed in the local environment versus someone who may have the brain involved? Because, I'll switch back to me, take my hat off. I tend, like when I teach about the gut in the seminars that we're in, we talk about some of the primary drivers, like things to think about when you're dealing with GI complaints. And one is, yes, what's happening inside the local gut environment. Second, thyroid has a huge influence on that. And then the third is the brain. So putting myself back into the perspective of a novice or a beginner, how do I differentiate between someone who just has gut stuff because it's gut stuff versus someone who has gut stuff, but the brain is involved? And then how do I determine if the brain is a primary problem or maybe even a consequence? Because you and I both know you can have a dysbiotic gut that the systemic inflammatory response then turns around and causes brain fog. So presence or absence of brain fog, is that a big differentiator? Like, how would you zero in to say, no, the brain's important in this case, And I guess that begs the question, how is SIBO different than just your run-of-the-mill dysbiotic gut? I'll let you go wherever you want to with that.
Yeah, I mean, there's just like three questions there that I think is really important to answer. Yeah. So first is, how do you know if it's just the gut or if there's a brain-gut involvement? Yeah. Well, if it's just the gut, then you'll have an absence of, brain symptoms. So remember, it's cortex and it's vagus nerve. So vagus nerve doesn't just control the gut; it controls other autonomic function as well. Yeah. So you can look for other autonomic sign to see if those are present. So if you have other autonomic sign present, then you know there's a vagus nerve involvement plus the gut. And also, when you have a vagus nerve involvement, it's going to affect function of all digestive function, right? So it's not just going to be, I have trouble digesting fat. Well, that might be a gallbladder issue. I have trouble digesting carb. Well, that could be a pancreatic issue or FODMAP issue. I have trouble digesting protein, but not the other two. Well, that might be a stomach acid problem. So then you start to kind of just separate out these things by asking very detailed questions about what type of symptom the person's have. And if you understand, kind of back to what I was saying earlier, what's the normal physiology of digestion, you know it really well, then you'll be able to separate out, right, what type of problem is it? Is it stomach acid? Yeah. Is it biliary? Is it pancreatic? Or is it vagus nerve? Because then with vagus nerve, you might see palatal paresis, you might see absence of gag reflex, you might see increased sympathetic tone, along with the SIBO and a digestive issue. So then that clues you into there's a brain involvement. Then the second question is, did it start with the brain? Did it start with the gut? Then that's going to come from taking a really good history, right? So one obvious example would be, hey, my digestions were all good until I had a concussion. Then my digestion is no good anymore. Right. Well, then in that case, probably started with a concussion, brain inflammation, causing decreased, cortical output to the vagus, then your digestion doesn't work. So then in that case, it's pretty obvious it's started in the brain. That doesn't mean you don't also fix the gut. It just means that there's definitely a brain component. Sometimes it doesn't really matter which started. It just matter what you got to fix, right? Fix what you find. Yep. And also maybe it also matters as far as, which one's more severe, maybe. Maybe somebody hit their head, but the concussion, it didn't result in so much priming of the microglia. So the brain's kind of healed, because not everybody hit their head and have the same consequence, right? Somebody hit their head, they're really resilient and they're just fine. And then maybe it caused some leaky gut. So now it turned into a gut problem and a SIBO problem, but the brain's kind of healed. So then you just focus on the gut. So you have to just kind of see what's the priority for that person. Yeah. How much does that symptom show up in the brain versus the gut? And so that's the cool thing about being a practitioner. You get to take your pick. In baseball, it's called fielder's choice. You want to throw them out the first, or you want to throw them out the second. You get to pick whatever's most important in that situation.
Yeah, one of the things that I often look at when it's uncertain what the primary agent is or the primary mechanism is to look at somebody's flare-up pattern and ask them the question, like, if you're flared up and everything is, hit the fan, so to speak, what's the first domino that falls? Like, do you find that you get brain fog or focus concentration issues? You get a mood shift, your brain is very fatigable, and then your gut starts to misbehave? Or is it the other way around? Your gut starts feeling a little bit wiggly, and then your brain symptoms come after that. I find that clinically helpful in trying to sort out some of these more confusing presentations, because I do think, like you said, there are very clear-cut cases, right? Like, it's very easy to say, okay, this is SIBO. Yes, the brain's involved. No, the brain's not involved. But then there's a lot of cases where you're not really sure if the brain's involved or not. And I think if it is involved, knowing if it's primary or secondary, are we dealing with a brain-to-gut axis dysfunction or a gut-to-brain dysfunction, right? It's because it's a bidirectional relationship. So that's one of the ways that I do it.
Add to that, Stephen.
Yeah, please.
I would add to that. Another thing is that sometimes you get to find out when you do a therapeutic trial, right? Maybe it's like, gosh, it could be the brain, could be the gut. Where do we start? Yeah. Sometimes there's no way to know because it's not that obvious, right? This is the practice and the trial that we go through, then failures. But there's no failure if you just know that, hey, let's try fixing the gut first and see how you do.
Yeah.
If that fixed everything, there's a wow, gut was primary, or gut is the primary thing
Yeah.
for you. If it's fixing the gut doesn't fix it, then you know to go to the brain. So you have this algorithm, right? You go here, it didn't work, go the other direction.
Yeah.
You have a choice. As long as you
Yeah.
have a map, that roadmap that guides you so that you know if this doesn't work, you have a backup plan, then you're all good.
Yeah.
The worst thing is you're convicted. It's like everything is all gut. So I fix leaky gut, I fix everything. And then when that doesn't work, you have no backup plan.
Yeah.
Then patients suffer and you don't know what to do.
Yeah. Yeah, and I like that approach as well, because sometimes the picture is not clear and you just have to do something that seems reasonable, and then you monitor the outcome, which is why, like, I'm not a huge fan, and I know some people practice this way, and I try not to disparage or cast aspersions on how other people operate, because I only know what I know, right? I see what I see, I know what I know, I don't know what I don't know. I'm aware of that, even though sometimes I don't operate that way. But, I know that there are some people who might put someone on, say, a gut protocol, like a classic 4R approach, and they'll say, okay, I'll see you in 3 months at the end of a 12-week process. And to me, that seems like an awfully long time to not touch base with someone to say, is this actually working? Right. So, and you can share how you do these things, and I hope you're not the one that does that, because then I would feel like a fool for having said that. But like, how do you approach the programming? We might be getting a little bit ahead of the conversation, but how do you approach the programming for dealing with SIBO in the bigger picture? And aside from considering whether or not the brain's involved or not, how do you differentiate, again, this is a gut with a SIBO element, so I'm going to do this, whereas I wouldn't do that in a case where it's just a dysbiotic gut? And there's a question in there. I hope you understood what the question was.
Yeah, the question is, how frequently should we have these touch points, right? So, and I think that the frequency of the touch point is going to be dependent on how clear the case is to you, right? So if the case is very, gosh, it could be one way or the other. I don't know how they're going to respond to this. So let's do a trial therapy and see how they respond, so we can know what the next step is. Then more frequent touch points.
Right.
Like I will see people every couple of weeks, right? Just hey, let's catch up.
Yeah.
See where you are. Either myself or my nutritionist, we're touching them and finding out how they do. Because if we're going to try something, I don't want to wait 3 months or 6 months to find out it didn't work and then pivot.
Yeah.
I want to pivot as soon as I can. Right now, other times where it's like, hey, it's pretty straightforward. You're not that complicated. You're not that severe. Then it could be longer. So I think that the touch point is going to be dependent on how much of a question, how uncertain are you?
Yeah.
Right. Meaning, there's 2-3 choices. We want to find out as quickly as we can which one of those scenarios play out for them. And that's something to be explained to the patient as well, right? Hey, we're going to find out which mechanism, which pathway is broken for you. We're going to find this out together.
Right.
And the only way to know it is by doing it.
Yeah. Yeah. And it seems to me that SIBO being, kind of following on the more complicated side of the clinical spectrum, right? It's not like it's just a simple dysbiotic gut, if that ever is to be considered simple. It's more complicated because there's more stuff involved. When you put together your programs, and again, I'm trying not to make any assumptions about how you do or don't operate, but when you're putting together programs for people, do you consider either your impression of how much hand holding they need, or do you even have a conversation like how often do you want to see me? Like I find myself periodically asking people, like, how much support do you actually need as I am putting together my recommendations of what the next 4 months or 6 months or whatever looks like. I will ask them, like, how much support do you need from me? And some people will say, I'm pretty well versed. When I know what to do, I'm going to do it. And then there are other people who are like, I normally don't follow through and I get confused. And I know on one person, I can afford to go 3 weeks in between consults, and someone else, I might need to meet with them every week for a while. So how do you manage that process? And again, we probably should put it in the context of SIBO, but I guess it's a broader question about how you approach clinical programming, especially dealing with complex clinical scenarios.
Well, I think it's always giving people choices, right?
Mm.
So kind of giving them plan, get options. Hey, here's a good plan. Here's a better plan. Here's a best plan, right? So then they can place themselves how they want to be held.
Yeah.
Because you can say that, hey, you need a lot of hand holding, but they don't want the hand holding. They can't afford the hand holding. Right, for whatever reason, they think they got it. So you can't force people into a scenario that they don't feel is right for them. So you just give them the option, and then you explain to them that, hey, I feel like this might be the best for you because for these reasons you need more hand holding.
Yeah.
But these are the three options. How would you like to proceed? And let them choose.
Yeah.
So then they're happy with it. If it doesn't work, then you can say, hey, you probably need more hand holding because I'm noticing that there's lapses and we're waiting way too long to find out, because by the time I show up 3 months later, as you initially wanted, by the time I find out it's been 3 months, you've been suffering, nothing's getting better. I would have liked to know that sooner. So the way I handle it is just give people options.
Yeah. So our conversations kind of meandered off into a whole bunch of different things, which usually happens. So let me refocus us, and let's go back to, you're the mentor, I'm the novice, and I'm coming to you saying, Peter, I've heard of this thing called SIBO. You just explained that the brain could be a key part of this. And I think I understand how to distinguish when the brain's involved and when it's not. But actually, what is SIBO? Like, what is it? Like, what's happening in SIBO?
Yeah, so that kind of goes back to an earlier question that I failed to answer. Thanks for reminding me, which is, what's the difference between SIBO and a gut infection, right? And so the SIBO stands for small intestinal bacterial overgrowth. Now, by the word overgrowth, you know that this implies that there's already bacteria that's supposed to be there to some degree. It's just overgrown, like it's too much, right? Because it's not like you're going to have a sterile GI environment, right? You don't have a sterile human being. We have like microbiome, we have the skin biome, oral biome, we have germs all around us. It's part of normal. So the goal is not to have a sterile human being. In fact, that's actually very negative, right? It's not good to have a sterile human being. But in a small, this comes down to anatomy as well. In a small intestine, you're supposed to have less population of these bacteria, right? There's some, but usually the stomach acid, if it's really strong, you have a lot of stomach acid production, and you have good vagus nerve function. You have that good downward beating motility, where bacteria is being swept through by the migrating motor complex, which is this periodic contraction that move food through the gut. Then the bacteria kind of just moves right along downstream, kind of like a river that flows. So food and bacteria all just flow downstream. So eventually, north to south, you eliminate it at the other end as feces. So then things don't get a chance to hang on and grow and colonize. So at any given point, you always have some bacteria in your small intestine. But the problem is if the bacteria is able to overgrow. So what situation will contribute to that overgrowth? Well, sometimes it's the regurgitation or the backflow of colonic bacteria, right? Because most of these bacteria are in a fecal matter in the large intestine. So if that segment, that valvular control, the ileocecal valve between the large and the small intestine is not working good, then you can have potentially some regurgitation of bacteria content back into the small intestine. That could be a reason for that. So that will be a vagus nerve or neurological control problem, right? Because anytime when you have a valvular problem, any kind of valve, there's smooth muscle. Anytime we have any kind of muscle, whether it's volitional muscle or smooth muscle, there's a nerve innervation to it. So the question is, why is the ileocecal valve not working? Some kind of valve, some kind of neurological control problem, right? So then that's one reason. And the other reason is because the internal milieu, like what you're feeding the gut, is causing situations where the bacteria can flourish, can overgrow. So then that could be, this is why alcohol is a potential contributor to SIBO. This is why proton pump inhibitors, where you're shutting down stomach acid production with these stomach acid inhibiting drugs, lowers your ability to kill bacteria through the stomach acid. So then more bacteria is able to get to the place where they're not supposed to be. And when these bacteria are in the small intestine, where normally they're in much smaller populations, when they're present in larger population, they can start to ferment against food that are on the way down, on the way to being digested, right? Because food goes from north to south. So in the northern part of the GI tract, food is not completely broken down yet. The further down it goes, the more broken down it is. So on the way to being broken down, but partially broken down, that's where the bacteria have an opportunity to ferment against those food. That's what's creating the fermentation, and therefore the gas, the bloating, all these symptoms that's associated, that's classic for SIBO. So then what we can use is very useful as symptoms to guide us as far as whether somebody do have SIBO or not, right? It's like a very telltale signs, which means that, hey, every time you eat, you bloat, especially roughage and fiber, you bloat. Okay, most likely a SIBO. Does it mean every time SIBO? No, but it puts us pretty close to the ballpark where we might be right. So then we can do a trial therapy and see if we're right. And if we're right, then we should see some kind of change relatively quickly. So that's how, when you understand that, it just makes understanding SIBO much easier. And of course, we can't forget about the vagus nerve influence that we talked about earlier, because that's what's driving the migrating motor complex to sweep the bacteria down the GI tract. That's what drives the stomach acid and all the secretions. So you're digesting the food to break it down into small parts, so you're not actually having fuel for the bacteria to be able to overgrow.
Yeah.
So having that framework is important, because otherwise we're just thinking about killing bugs all the time. Oh, you caught an infection. So let's answer this question. What's the difference between SIBO and a gut infection? Well, SIBO is an overgrowth of an existing commensal bacteria that's already there due to various other factors, not because you caught something necessarily. Where a gut infection is where Salmonella, E. coli, you ate some bad foods, food poisoning. That's kind of a pathogenic gut infection. So that's the difference. One is more of a physiological contribution that's allowing the bug to overgrow, where the other one's actually you introduce something, a pathogen, and that's taking over.
Yeah, and maybe we can draw the distinction between an infection in that classical sense of like something that should never really be there versus a dysbiotic environment or a commensal overgrowth where you just lose control of the environment and something that's there in small amounts is allowed to populate, and the numbers start to shift in favor of things that are not considered your probiotics. So we went through, and you did a great job by that, by the way. If you could condense it down to a list, like you mentioned the ileocecal valve, you mentioned use of PPIs or proton pump inhibitors and change in hydrochloric acid status. If you could offer a novice a list of things to think about as causative mechanisms, what would that short list be? What would that look like?
Yeah, so the list will just follow the clinical model, the roadmap, as well as follow the digestion physiology. So I start with, do you have brain symptoms? If you have brain symptoms, that can potentially impact the vagus nerve. Then I ask, do you have vagus nerve symptoms? Then you're checking autonomics, symptoms, and signs. And usually with vagus nerve, then it's digestion of everything's compromised, right? It's not going to just be fiber and roughage, which is classic in SIBO, right? So then if the vagus nerve is involved, then you might have trouble digesting fiber and roughage, but then also not make enough stomach acid, so protein and fat digestion with biliary issues. So then we just go down the list: brain, check vagus nerve. Next, assess whether there's enough stomach acid secretion. Ask questions. And then next we see if there's a biliary problem, bile issues. So we just go down the GI tract following the path of physiology, and then eventually we'll end up in the small intestine. And then leaky gut could be a contributor there, but I think leaky gut is more, if you have SIBO can cause leaky gut. But just remember, there's a dysbiotic situation there with SIBO, right? It's almost like SIBO is dysbiosis, right? SIBO is how one expression, one way of having dysbiosis is SIBO.
Yeah.
Not everybody with dysbiosis have SIBO, but you can have dysbiosis that show up as very pronounced diagnosable SIBO condition. And to me, dysbiosis is simply an imbalance between the good and the bad, right? So what that means is, in fact, it's not just imbalance between good and the bad. It's an imbalance between your immune system and the bacteria that are in your gut, whether they're good or the bad. Meaning you can have way too much beneficial bacteria, and that's dysbiosis too. People tend to think that, these beneficial bacteria, because they're beneficial, more the better.
Yeah.
No, if we do a GI stool test, and we're seeing like way overabundant of all these commensal beneficial bacteria, that means that the tug of war between the immune system and all the bacteria in your gut, whether beneficial or not, right? So it's kind of like the battle here is between your immune system and all the organisms that are growing in your body. Your immune system always have to keep that balance of keeping these organisms in check, whether they're beneficial or not, Because if your immune system's not there, the good guys and the bad guy, they will all overgrow. That's the definition of dysbiosis. I think that's important to underscore because a lot of people just think like, hey, just shove more probiotic down there. That's going to solve all my problem. But sometimes it's an immune system suppression. So if your immune system's not home to keep all these bugs under control, too much bug of any type is going to drive inflammatory issues.
How do you interpret it when someone takes a probiotic either on their own or prescribed by somebody and they get SIBO symptoms? Like how do you interpret that?
Yeah, so sometimes, we know certain type of SIBO patients and certain type of SIBO conditions where the probiotic can actually be fodder for the SIBO, right? So the probiotic becomes like food. We know most of these probiotics, they don't make it all the way down the GI tract, right? Because most of the probiotic, they're kind of dead on arrival, right? The stomach acid kills them. And a lot of these probiotic, they have to be refrigerated. Well, if you have to refrigerate the probiotic, if it's that weak, how is it going to survive the GI tract all the way down? So, but that doesn't mean the probiotic is not useful, right? Just because they're dead on arrival, they still serve as either nutrients for other bacteria. Bacteria is not that picky with food, okay? They'll eat whatever. so the dead bacteria from the probiotic could be food and nutrient for other bacteria that are already there. They can serve as signaling molecules to kind of influence immune function and so forth. So they're still useful. Doesn't mean they're dead, they're not useful. So I think sometimes when people take probiotic, it could be serving as fuel or food or nutrient for the overgrowth bacteria there. Sometimes it may be just you're feeding more probiotic and maybe whatever probiotic may get down there alive, it's just adding to the fact that what I talked about earlier, if your immune system just not there, you add more probiotic, you're just adding to the bacterial load. And it's kind of like this immune system bacteria bistable balance that you're losing the battle with. Yeah. And so feeding more bacteria when there's already way too much bacteria of any type, it's going to just drive more inflammatory response.
Yeah. And I find quite often people who don't tolerate probiotics in this context, the probiotics they're taking quite often have prebiotic fibers that are fermentable, right? So they might have inulin or chicory or fructooligosaccharides or arabinogalactans, things that the overgrown bacteria can munch on and then start producing their characteristic gases. Have you seen any of the literature? And I think admittedly this is probably more rare than other mechanisms, but have you seen any of the literature where the mechanism of some cases of SIBO is actually autoimmune, where it starts with typically a viral gastroenteritis that resolves, but then there's immune cross-reactivity between the viral pathogen and target proteins in the migrating motor complex, like vinculin. And what people are left with after that viral gastroenteritis is they're left with an autoimmune SIBO. Have you seen any of that literature?
I have seen the literature. There's tests for it. You can test anti-vinculin antibody and anti-cytolethal
distending toxin, CDT.
There you go. Yeah. Yeah, so you can test for it. So it does happen. I'm not sure how prevalent or what the incidence of that is.
Yeah, and that's why I started by saying, I think it's in terms of mechanisms causing it, I think it's on the rare side. But just to kind of translate this into something that might be more clinically useful is when do you start thinking that maybe this case is an autoimmunity? Well, first of all, if whoever you're dealing with has other autoimmunities, because we know that they tend to happen in clusters, but also if all their GI issues started after an acute GI infection, right? That's a big telltale, kind of like, my gut went bad after I smacked my melon and had a concussion, right? That kind of clues you in, and it highlights what you said earlier, the importance of really doing a thorough targeted history to really understand what the mechanism is. So we're talking about diagnostics. Let's kind of pull back and ask the question about relevant diagnostics for SIBO and then how you handle that in your practice. Because I do things the way that I do it. You might do things a little bit differently. But what's your knowledge base on tests for SIBO? What's available? and whether or not those are clinically reliable. Should people be using them? And if not, what's the fallback?
Yeah, so I used to do a lot of breath tests, the small intestinal, the SIBO breath test, okay, and it measures methane and hydrogen gas. And I find that it's accurate when it's accurate. Okay, so what that means is if it's positive, it's positive.
Yeah.
If it's negative, it doesn't mean it's negative, because it turns out, these bacteria can produce other gases besides methane and SIBO and hydrogen gas. So now there's a Tri-Smart test that measures 3 different type of gases. And, supposedly it's better. And of course, you're getting more data, you could potentially catch more. But, what I've noticed is that a lot of people come to my practice already having some of these tests done. So I'm looking at their tests and I'm saying, okay, so you have this positive test. What I do is I try to find out, what did you do for it and was it effective, right? So I want to evaluate, did they actually fix all the different boxes that I would check? Yeah. Right? If they just say, oh yeah, I was positive for SIBO, I took antibiotic, did I fix it? No. Okay. Or it came back. Yeah. Then I'm asking, okay, so let's go north to south again. Yeah. Make sure the vagus nerve and stomach acid, because you may have missed something. If they had a test come back and then it shows high, a positive SIBO test, but then a lot of time what I'm asking them is, okay, what is your actual symptom? You've been told you have SIBO. What is your actual symptom? Do you have bloating? It's like, no, I don't have bloating. Okay, so what does that mean? Because, at any given point, you have like probably 10%, 15% of the population who are asymptomatic that will test positive on the SIBO test. So what does that mean? You produce some of these methane, hydrogen gas, but it's not affecting you, right? So I've seen a lot of people, not a lot, I've seen a good fair number of people who come with a positive test and are told they have SIBO, and they carry this diagnosis on their back, but they don't actually have actual symptoms of SIBO, like nowhere near it. Yeah. They have brain fog. So it's, okay, could the SIBO just manifesting purely as brain fog? Well, I'm not sure. It could. It's possible. But usually if you have SIBO, that means the bacteria is fermenting and it's against FODMAPs. And so you should have some gas and bloating. If you have no GI symptom, then I'm reluctant to say that you have SIBO. And sometimes it could be just like, oh, the test is 3 years old. Do you have SIBO now? Yeah. Sometimes people carry a test around from 5 years ago and they say, I still have Candida, I still have SIBO, but maybe you don't anymore. And it's morphed into something else. Yeah. So we got to go fix the more relevant thing at this point in time. So it's almost like just being a detective and asking good questions and not be married to a diagnosis, right? Not be like, oh, you have SIBO. So like, well, let's just keep fixing SIBO because that's what's obvious. You tell me you have SIBO, so I'm going to believe you. Yeah. I never just take that and then believe whatever the test is or believe whatever previous doctor diagnosis. I always got to find out if that's actually presently true. Yeah. And that allows me to work on the things that's relevant to that person.
Right. Do your own due diligence. So would you say, and I'm trying to summarize some of the key points of what you shared, would you say that when you're trying to assess whether or not somebody has SIBO, and you understand that quite often the brain is involved in this, number one, look for a bigger picture of neurological symptomatology, particularly if brain symptoms flare up and then gut symptoms follow. And then key in on the gas and the bloating that tends to happen fairly quickly after consuming certain types of food, right? Even though with a brain gut axis problem where the vagal system is compromising digestion of all macronutrients, with SIBO, it seems to be pigeonholed to fibers and starches, things that are fermentable, right? The so-called FODMAPs. And we should probably define that here in a second. Do you think that that's a fair big picture approach? Is number one, think about the brain. And number two, if you're going to call something SIBO and then program for that, you really have to have this picture of bloating and distension associated with eating certain types of foods. Do you think that's a fair, really big picture approach? Because there's obviously a lot more going on with SIBO.
I think that's a great starting point, because if you don't have any gas and bloating, so then what are you trying to fix, right? If you're trying to fix SIBO, because if this person just has brain fog and depression, but no gas and bloating, That doesn't mean they can't have gut problem,
Right.
but it's a SIBO.
Right.
You don't want to program for SIBO when you should be programming for leaky gut or programming for restoring the gut microbiome versus like trying to address SIBO, because it's different. The diet's different. The supplement protocol might be different. So I think, you got to, if it's SIBO, it's going to look pretty, it should be carrying the characteristic, right, symptoms of SIBO.
Yeah.
Now, that doesn't mean some people can't have both a local problem and a vagus nerve problem. They're both happening. There's always multifactorial.
Right.
But I think that's a good overall picture, is check the box. Is it brain?
Yeah.
And is it, you have SIBO symptoms? I will even, that's a good starting point. But I think later on, as you start to, you check those boxes, then what else is causing it? Then you start to ask, what are you eating? What's your lifestyle? What's the stress level? But then another thing that will definitely check the box is immune function. Like, do you have some level of immune suppression that's causing you to not able to manage the bugs in your gut?
And so how do you key into that? Like, is it just a history of frequent colds and flus? Is it a picture of systemic inflammation? Are you looking at white blood cell count or a lymphocyte biome? Like, how are you trying to answer that question? What's the immune system part of this picture?
Yeah, it's a combination, right? So we're looking at definitely lab work, right? If we're seeing low white cell count, we're seeing or imbalance between the CBC differentials between lymph and the newts and the eosinophils. I'm looking for, do they have history of infections, not just colds and flu, but sinus infections, bladder infections, kidney infections, lung infections, gut infections, right? Because all these mucosal surfaces are kind of tied together. So if you have decreased mucosal response, it's not going to just show up in the gut. It could show up as chronic UTIs, chronic sinus issue. So then those things will clue me into that, your mucosal immune response is not great.
Right.
And so you're getting all these different things, and then you have this, SIBO problem, and we see low white blood cell count. That puts together a picture, right? We're trying to build a case. There's a preponderance of immune suppression. You also have heavy metals. You also have history of toxic chemical exposure, which are immune suppressants. Yeah. So then you put this picture together, and then you say, let's try to address the SIBO, not just from the perspective of killing the bugs, but also building up your immune system.
Yeah. Would you say that if somebody thinks that they have SIBO and they either go on a course of antibiotics, which of course would be the medical approach, or if they go through some kind of a natural medicine program, let's call it the 4R protocol, which is fairly commonly used, I think, in our world. And that is successful. And it's successful in a short period of time, let's say 8 to 10 weeks. Regardless of whether or not they had, let's assume that they had gas, bloating, and distension to begin with. But a simple course of antibiotics or an 8 to 10 week 4R protocol completely eliminates the problem and it doesn't return. Would you go back then retroactively and say, well, that probably wasn't SIBO? Or would you say that was a mild case of SIBO and we were just successful at beating it in that moment? Like, how would you interpret that scenario?
If they take antibiotic and the SIBO symptom resolve and does not come back, first of all, assuming you actually do your due diligence and you actually come to the conclusion that it's SIBO and not other issues, then you have to say the antibiotic kind of took care of it. Maybe it's a mild case. Of course, it's always possible that they just have some other bug and the antibiotic just took care of it. Right? Sometimes the body just needs some help. Yeah. It needs some exogenous help to kill the bugs so your immune system can get back on top. We don't have to sterilize everything, but it just needs some help. Right? Once the immune system gets it back on top, it'll just take over and do its own job. So I would think that if they take antibiotic and their symptom improve and doesn't come back, that's, to me, it's either SIBO cleared up or some kind of gut dysbiotic situation got kind of improved by the antibiotic. The 4R protocol, obviously, it's not going to be as like a nuclear bomb effect like the antibiotic would be. So the antibiotic will be very clear-cut answer like, oh, you got a bug, and that's why the antibiotic worked.
Yeah.
If you did the 4R, there's other things that we're doing in 4R. They changed their diet. We're healing leaky gut. They're taking natural antimicrobials. So it could be any number of those things that also help with the SIBO. Yeah. I think that the starting point is that actually SIBO.
Yeah.
Right. And sometimes you do the 4R and to fix it, it could either prove that it's SIBO, it could be proving that it's leaky gut or some other issue that got fixed along with it. But either case, if it doesn't return, that's a good sign. If it returns, then it means that there may be biofilm issues, there may be again, other issue that's not addressed yet, like vagus nerve.
Yeah, and that's kind of what I was thinking is that, like, if you have success either with antibiotics or for our protocol, and then you get recidivism, right? You get a return of the problem. To me, that speaks very strongly that the piece that's missing is the brain. Like, I always tell people, like, once we've eradicated the infection, and I use air quotes for that word, the job's not done, because now we need to make sure that the immune system competence and control is rehabilitated so we don't get it back. Now, that might involve dealing with the brain if the brain's involved. It might involve dealing with a leaky gut. It might involve merging into maybe a biotransformation detoxification protocol, right? There's any number of things, and that's obviously case specific. But your last little answer kind of begs a couple of questions. Number one is, do you see SIBO as a single entity that's very well defined, or as more of a spectrum? And how, like, as a clinician, what changes in your thought process and approach if it's a recent onset problem versus it's something chronic like they've had for 10, 15 years, or let's say 3 years. Let's just shorten the time frame. So, two questions. One is, are we dealing with a spectrum? And if so, what does that look like on either end? And how do you interpret it, or how do you approach it, or see things differently if it's a recent onset problem versus something that's chronic? So time and scope.
Yeah. So as far as the spectrum question, it could be a spectrum of intensity or severity, right? So it could be a mild case SIBO versus severe case. But also the spectrum question, I think one thing that pops into my mind is that not everybody with SIBO are fermenting or have trouble with the same foods. Because I've had patients who have SIBO, this list is supposedly the SIBO list you're not supposed to eat.
Yeah.
And they're like, well, hey, doc, this whole time I cheated. I've been eating garlic this whole time. I can't live without garlic. And it's on the not to eat list, but I ate garlic, but I still got better.
Yeah.
Right. Or somebody else said, like, hey, I ate onions and I was fine.
Yeah.
So I started to realize that not everybody react to the same thing, right? The SIBO bacteria, it's not like you have to follow the SIBO diet or it's not going to work.
Yeah.
So I realized that there's a spectrum of food that people can react to. Some people, they it's all the FODMAPs. If they touch any of it, it's bad. And other people, it's like, it's kind of loose. You can kind of have here and there. And then as they get better, how do you know they get better? One of the ways you know that they get better is that they can start tolerating FODMAP foods.
Yes.
You just put these food back, they can tolerate it, they got better.
Exactly.
That's one way we can tell, right? So that's that spectrum, that I think about. And then as far as intent, the time question, if somebody had it just recently versus somebody who had it for 3 years, the more recent, then it's more likely the problem's going to be more likely easier to be fixed by addressing the gut component of it, although we still have to go through the checklist. Yeah. If somebody had it for 3 years, then the question is, what have you done in that 3 years, right? Because maybe in the 3 years, they haven't done much. Okay, then we just go through, do our regular things that we would do, right. Check through the list. But I took antibiotic, I took a bunch of herbs, I saw a bunch of functional medicine doc, I already did a 4-hour protocol, then it's time to ask, again, just take the framework, and then we're asking about the immune system question that I brought up earlier, right? So, okay, I'm already doing gargling and humming and vagus nerve exercise. Okay, there's always questions to be asked there, right? How intense? Yeah. How long do you do it for? Are you doing it correctly? Yeah. But then I started broach into questions where it started to get into like the terrain question, right? Is your immune system right? And why is it not right if it's not right? Is it because of toxicity problem? Is it because of sleep? Is it because, any number of things? Right. So then that becomes more of a complete case that you're actually, right? Now it gets into the full roadmap, not just the north to south, then we're in brain, immune, gut, endocrine, all of that combined. We have to assess it all.
Yeah, it's kind of interesting because when you start with this north to south approach, right, this hierarchical integrated systems, at any, you can stop at any point and then dive in and then subdivide each of those, right? So you talked about the brain. So, maybe there's a cortical issue, or maybe there's a vagal output system. And then you dive into the vagus. What does it do? What does it control? What influences are there over that? and then how can we drive vagal output to improve its control over the GI system. Then you can go into the gut and ask the questions about the terrain of the gut. So you're thinking about leaky gut, you're thinking about the biotic or the microbiota and whether or not there's dysbiotic overgrowth and enzyme production and secretion. And so it's like you have this big picture, north to south, all the stops along the way. And then our job clinically is to go into each of those pieces where we're seeing problems and then subdivide those out into functions and mechanisms and triggers and perpetuators. And then I think if you walk through that process, you end up with a very robust understanding of what's happening and what are your opportunities to go in and start making changes from a clinical perspective, right? And then, it kind of brings me back around to the very, very first question. It's like, what's the right way to think about SIBO? Is it about finding the best enzyme, the best probiotic, the best herbal pathogen killer? Or is it about having the right model first and then bringing that understanding of the scope and the scale of the problem and then developing your protocol out of that rather than having a SIBO protocol, which, you and I both know, maybe more than 50% of the practitioners out there have a SIBO protocol, right? That's just, they do it the same way all the time.
Yeah, I see protocols as like tools, right?
Yeah.
You have hammers, you have screwdrivers. Whether you use hammer or screwdriver depends on the job at hand.
Yeah.
You don't start the project with like, I'm going to do whatever project I want as long as using my hammer. No, you say, okay, I'm gonna build a bench, so I need a saw,
Yeah.
right? You don't need maybe a hammer right off the bat. So the framework is the blueprint for how you're going to build whatever it is that you're trying to build.
Right.
The tools are the supplements and the different things.
Right.
So you pick your tools and your weapons depends on what you're trying to fight. It's
Yeah.
mission specific.
Yes.
Right? So don't start with the weapons or the tools. Start with the plan.
Yeah. All right. So how much time do you have left and available?
10. Hard stop in 10.
Okay, hard stop in 10. All right. So let's do this. Let's define FODMAPs because we've mentioned that a couple of times without defining it. And then we'll merge into the final segment, which is, Dr. Peter Kahn's advice to novices and beginners, just kind of encapsulating. So what does FODMAP stand for? It's an acronym, right? FODMAP as in Paul. What does that stand for? Why is it important to understand that in the context of SIBO?
So it stands for fructo oligos polysaccharide.
Let me handle that. It's fermentable oligosaccharides, disaccharides, monosaccharides, and polysaccharides. And basically, it's an acronym that refers to foods that are more fermentable than other foods. And we're talking predominantly about vegetable matter, right? Fruits and vegetables. And so when something...
It can be grains too, yeah?
What's that?
Sometimes it can be grains as well. It can be grains as well.
Grains as well.
Lectins and beans.
I would say universally grains, personally.
Right.
Yeah.
Right.
So understanding that FODMAP or FODMAPs refers to a class of foods that are fermentable, grains, fruits, vegetables. Why is it important to understand what they are, what they do, how somebody's gut with SIBO is handling those things, and then using a low FODMAP diet as a therapeutic tool, but also, as you mentioned and hinted to earlier, almost as a diagnostic tool to check progress. So I'll let you answer that, and then we'll go into our final segment.
Yeah, so the FODMAP is important because it can be a diagnostic tool, right? So if you ask the good questions during history and the patient's telling you, yeah, every time I eat all these food that contains high FODMAPs, I don't do well. That's pretty much a shoo-in that it's most likely they're having some kind of problem with FODMAP, either caused by SIBO or some problem not able to digest them. So that's very useful. So then we can then use that to implement a lifestyle dietary program for them to reduce FODMAP exposure, right? Don't eat them so much. So then they don't have that, problem of feeding the bacteria that's exacerbating the symptom and potentially just exacerbating the bacterial overgrowth because it's a problem of overgrowth. You give it more fuel, then it might just grow more. Now, what I would say about FODMAP is what I alluded to earlier. Not everybody reacts to the same FODMAP. And remember, going on low FODMAP is not going on FODMAP free.
Mm.
You don't have to be free of FODMAP. You just got to eat less of them. How much less? Everybody might be different.
Yeah.
Some people have to be like completely, strictly eliminated just to feel some relief. Other people, they can have a little bit here and there and still be able to get better. So how do you know? Well, usually what I do is I start with being very strict, see if you respond, right? And then as you get better, then we can put things back. Because some people, they have to go super strict to be able to feel some kind of relief. So we don't want to start by, oh, just dabble, and if you don't get better, we can get stricter. Let's just kind of go all the way, get the patient's commitment and see how they do. And then we can introduce things back as a way to tell that they're better. But the important thing here is to know that it's low FODMAP, not free of FODMAP. So you don't have to put that pressure on yourself to eliminate all of it, because it's not necessary in all cases to do that, to get better. If it's uncomplicated, purely just like maybe more gut concentrated SIBO without any other extenuating circumstance where the immune system and the brain's not working, typically you cut out SIBO, you get pretty quick symptom relief because you're not feeding it, right? You're not giving that, because it's fermentable, right? The FODMAP is the fermentable, and the bacterial overgrowth is fermenting with those foods. So if you don't give it a thing to ferment, there's nothing to ferment. So they should notice improvement pretty quickly. So that's the good news, is that we can tell quickly whether that is the case or not, and then pivot if it's not working or do something different.
Hey guys, it's Steve here, and I'm just breaking into the flow of the interview for a moment. As I was doing post-production on this episode, I realized for some reason during the last few minutes, my side of the conversation dropped out. So just to fill in the gaps, I asked Dr. Khan if he had any advice for doctors who were in clinical practice, not doing functional medicine, but who wanted to start integrating functional medicine into an existing practice. And here was his response.
Yeah, so I think my advice is first be clear on what you're trying to do. Sometimes people get into functional medicine and they have the wrong idea about it. They think it's just like, treating people the same way. Instead of giving them a drug, I'm giving them a supplement. So essentially practicing allopathic medicine, but with a supplement instead of a drug. That's not what functional medicine is. Green pharmacy, yeah. So I think people should be very clear on what they're getting into and if that's actually what they want. And then secondly is get training, right? So get proper training from Dr. Noseworthy's Apex and any number of great institutes, IFM, so that they can develop their own framework, right? In the beginners, you'll have to use other people's framework because you don't got one. But once you practice enough, then you can start to build your own framework. Again, I think I've been asked this many times, and my first advice is like, why do you want to integrate functional medicine into your practice, right? Because sometimes people, again, they don't know what it is. They think it's this, but it's not. It takes a lot of work and thinking, and you have to kind of implement systems in your practice that's different. And in my experience, it didn't really, for me at least, for other people, I've seen practitioners able to kind of have a regular medical practice and also have a functional medicine practice in their same place. But for me, patients who are used to seeing me as a regular chiropractor, they didn't really follow me into my functional medicine practice. So it's kind of like, right, they see you as a chiropractor. It's like, what are you doing? You're nutrition? No, I already got somebody for that. So I think you have to know what you're going after and whether you actually want that. I literally have chiropractors come talk to me and they think like, I just sit on the beach because I'm doing all virtual work. They think I'm on the beach sipping margaritas and not doing any work. Like I work hella hard, So this is not for the faint of heart for you to do functional medicine. You can do it very successfully and help a lot of people. I believe you can help more people, but you just got to know what you're getting into. And then secondly, I would say for the docs who are already practicing for a long time to want to get in functional, again, get training. And my always advice is always for people to remember back to the basic sciences. Like, don't forget your, for neurologists, right? Functional neuroanatomy. Just, you got to know your anatomy really well to be a functional neurologist. And for functional medicine doc, you got to know your physiology really well. Dive back into it and use that as a way for you to, okay, I'm trying to restore normal physiology. I'm not trying to treat a disease. I'm restoring normal function. But you got to know what normal is first.
And that was Dr. Khan's final words during our interview. So just to give you a big picture overview for SIBO, first of all, SIBO is not your run-of-the-mill GI infection. It is a complex, multi-system, multifocal problem. So you have to think more broadly and more systemically and systematically when you're programming for it clinically. The key clinical indicator that somebody has SIBO is an intolerance to fermentable foods, the so-called FODMAPs. And just for clarity, again, that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And the intolerance that we see manifests as bloating and distension, which come on very quickly after eating these fermentable foods. Now, there are a ton of low FODMAP diet lists out there. There's even some smartphone apps that can be helpful. But know this, is that everyone's FODMAP list is a little bit different. And that's because there's a lot of individual variability in how people respond when they have SIBO to eating these more fermentable foods. So everyone's tolerance to the foods is a little bit different. For example, garlic and onions tend to be one of the classic foods that people tend to get gas and bloating from. Same thing with the brassica vegetables, so cauliflower, broccoli, Brussels sprouts. And then, of course, there are other foods there as well. But one of the things that didn't come out as we chatted was that sometimes the intolerance is not absolute in the sense of you're going to react to this all the time, but it's quite often conditional upon quantity. So some people can't eat any broccoli or garlic or onions at all, for example, while others can eat small amounts. And what we find is that if someone starts out having to completely avoid something like broccoli or cauliflower, etc., that as their SIBO begins to resolve, they can introduce small amounts into their diet and tolerate that as long as they don't go over a certain quantity. So sometimes quantity makes a big difference. But as Peter said, it's best to start with strict avoidance for a period of time and then merge into a quantity-controlled introduction or approach before adding things back in larger quantities that you might consider normal during the routine course of a typical meal. Now, there are some SIBO-friendly probiotics that are out in the market. They're made by different companies. Some people can handle them, some people cannot. And it is a good idea at some point to have people with SIBO on probiotics. The question is, when do you start and what do you start with? And so I would encourage you to do some trial and error in the beginning. Start with SIBO-friendly formulations in small quantities. And if these probiotics that are typically considered SIBO-friendly tend to blow up the gut and cause bloating and distension, just stick them aside or put them aside and then try it again in a couple of weeks and see if you can generate tolerance as you continue to go through the programming. Other than that, there are no specific antimicrobial herbs that I'm aware of that tend to work better than others. Sometimes what works in one person is not as effective as what you might see in somebody else, so you have to be flexible in your mental approach to how you program this. Simple things like digestive enzymes, of course, can help. And don't forget the brain. That was Dr. Khan's main point. As he mentioned, check the brain for general complaints like brain fog or fatigability. Look for a history of head injury. And more specifically, when someone complains of not being able to swallow pills or they tend to choke on food, that implies that the vagal control over the swallowing mechanism is compromised. And since the rest of the gut is interconnected to these neurologically, these are big clues that the brain is a primary driver of the SIBO, particularly in unresolving cases. Now, in these cases where people have faulty swallowing mechanisms, you can have them do gargling exercises or gagging exercises like with a tongue blade. They can even use their toothbrush, for example. And that can actually strengthen the tone of the vagal system, which then allows it to have better control over the gut. Now, one final word here. Dr. Khan and I talked about the scope and the time scale of SIBO, right? SIBO can be simple or it can be complex. It can be a recent onset or it can be a chronic issue. And so the more complicated the presentation is in the bigger picture, and the longer someone's had it, particularly if the brain is involved, it means it's going to take more work and it's going to take longer to resolve. So you cannot treat every case of SIBO the same. For me, as a general rule, and I'll just offer this as my perspective, anytime I'm working with someone with SIBO, because I'm always surprised. I shouldn't say always. Sometimes I'm surprised. But in general, I tell people if we have SIBO, we're in for, at least 16 to 20 weeks of work before we can consider the job to be done. And ultimately, the true test of whether or not SIBO is resolved is if people can reintroduce the higher FODMAP foods in normal quantities without experiencing the classic bloating and distension that is so characteristic of SIBO. All right, guys, hope that helps. Hope you enjoyed the interview and the podcast. Thanks for listening to the Func Med Nation.